Welcome, everybody, to the Genomics Virtual Week of 2020. My name is Matthew Ferber, and I am a Clinical Laboratory Director in the Department of Lab Medicine and Pathology here at the Mayo Clinic. I am a clinical molecular geneticist by training, and today I would like to talk to you about population health and genetic testing. Again, thank you for joining us. Hope everybody is staying safe and practicing social distancing. This is a fantastic venue for us to learn, share, and of course, remain appropriately distant from one another in these challenging times. So thank you for joining us, and I look forward to speaking with you throughout the next 30 minutes or so. I'm going to start off with just a couple of disclosures, nothing to spend a lot of time on here, but it's important that as we go through the descriptions of population health studies that Mayo Clinic and others are engaged in, we are working on those studies in collaboration with a for-profit laboratory by the name of Helix. Helix is a for-profit company. Mayo Clinic has a small investment within the sequencing technology of that laboratory, but none of our employees have a financial interest within the company. Okay, housekeeping out of the way, I'd really like to organize the talk into 4 different sections. We're going to bring up the beginning with a background and information about basic population health. And then we'll describe how or whether or not genetic testing actually fits in to population health strategies. I'll try to demonstrate that through some interesting examples. And then towards the end of the talk, we'll open it up for some discussion, or at least I'll provide some discussion, and then you can hit me back with any questions through email after the talk is over. So what is population health? If you take just a strict dictionary definition of population health, it comes down to the global study of health outcomes in a defined cohort of individuals. But the World Health Organization in 1946 took a much broader view of population health, and they said that it's not just the complete physical, but it's also the mental and social well-being, and not merely the absence of disease or infirmity that's important when considering population health initiatives. The form that we're most familiar with takes the form of more population health management. This is how large providers or insurance payers manage their overall population. A significant number being very healthy and another significant proportion having some sort of disease, which of course costs that provider a lot of money to help treat. So they use different tools and strategies to help manage that population so that they can spread their costs, spread their efficacy towards the best population to affect the best health outcomes. I think we're all familiar with a number of different population health initiatives. If we just take a step back and think a little bit more broadly, newborn screening has been around for many years. We know what a significant positive impact this has had on the health of the globe, the United States for sure. Phenylketonuria, or PKU, used to be a disorder that children died at a fairly early age without much understanding for why. But now with newborn screening, we're able to identify those individuals before they become symptomatic and begin treating them, and they live long, healthy lives. Same can be said for sickle cell anemia and cystic fibrosis, all wrapped up into newborn screening protocols. We now have expanded newborn screening that varies by state, and over 100 different conditions at times can be screened for within these public health initiatives, all trying to improve the health of that cohort. Other examples include HIV screening or neural tube defect screening in expectant mothers, especially mothers of advanced maternal age. We're in the current pandemic scenario right now, so we may expect at some point, once we are able to gear up testing, that COVID-19 testing or other infectious agents may become population health initiatives so that we can better the health of the nation and of the world. And then a lesser known, probably not to this audience, but if we were talking with a lay audience, a lesser known population health initiative just launched in 2015 was the All of Us study, launched by then President Barack Obama, who said, "Tonight I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes." I think the real motivating factor behind this is, with over a decade and a half, almost 2 decades since the sequencing of the human genome, we still struggle to really take full advantage of the power of that genome information. And so by announcing this public health initiative, All of Us, President Obama really envisioned sequencing over 1 million United States citizens from vast different backgrounds and ethnicities in order to compile that data in a way that would teach us how we can use genetic information in everyday health in order to better the globe's population health initiatives. I don't want to brag too much, but I'm very proud to say that the Mayo Clinic actually is the biobanking facility for the All of Us study. And as of 2019, at the close of 2019, I should say, we had well over 175,000 participant samples already received on site. And from those samples, we make multiple different sample sub-aliquots of different types: blood, serum, plasma, all of that stuff. We have over 4.5 million individual specimens banked in support of the All of Us initiative. So that's a basic background on population health. Let's talk a little bit then about how genetic testing can be used in population health initiatives. We know that genetic testing, the cost of genetic testing continues to go down. So how do we leverage these now powerful tools that are less expensive than they used to be in a way that helps us to cost effectively improve the overall quality and care of the population? If I were to restate that as a question, the answer to the question would be yes, we're ready to go. But the follow-up question very quickly is and should be, where do we start? We know that the human genome is comprised of over 20,000 genes. Some of those genes, relatively few, we know a lot about, and we know how they impact your health. The vast majority, we know, have some type of function, but it's unclear how they actually impact your health status. So where do we start? We start with what we know. It's quite simple. Now, the Center for Disease Control and Prevention created a statement a couple of years ago about population health and population health genetics specifically. It's not a full endorsement of population genetics, but it is a statement about the types of disorders where we feel and they feel the scientific community and the healthcare community could have the largest impact. This list has been compiled and is now known as the CDC Tier 1 genomic applications. And in the link that I've provided below, in the slide that you're looking at right now, it will take you directly to their statement with a little bit more in-depth information about the types of genetic conditions that they feel meet the criteria for both being understandable and treatable in a format that is consistent with population health testing. And the reason that they believe this for the CDC Tier 1, and sorry to keep you waiting, but we'll talk about the genes right after the next slide here, but they believe that over 2 million people in the United States are at increased adverse risk for negative outcomes related to these genes because these conditions are not being appropriately screened for otherwise. And although there are guidelines for who should be tested, they're not well known throughout the entire practice. So here's where an unselected group of people could benefit from direct testing of these genes for these conditions. What are they? I know you're waiting on pins and needles to find out what conditions they actually are. Within the CDC statement, the group has focused on 3 different global areas of diseases. One is hereditary breast and ovarian cancer. Two is a colorectal cancer syndrome known as Lynch syndrome. And the third is familial hypercholesterolemia. Again, these three, because of two main factors, maybe three, but the two main factors are we understand the genes and we understand what alterations within those genes do. And when we have alterations within those genes in an individual, we know how to treat them next in order to minimize their risk for disease. And three, I guess if I were to go and say a three, we know that these are significant population health concerns, conditions with population health concerns overall. And we're better to treat them ahead of time, identify them ahead of time, than treat them after somebody has come down with something like breast cancer, colon cancer, or familial hypercholesterolemia. So the genes that we'll be looking at are the BRCA1 or BRCA2 genes for hereditary breast and ovarian cancer. For Lynch syndrome, we'll be looking at MLH1, MSH2, MSH6, PMS2, and an associated gene called EpCAM. And for familial hypercholesterolemia, we'll be looking at the ApoB, LDLR, LDLR associated protein, and PCSK9. So the CDC's statement on population genetics says for those genes that we've just discussed and we've described, at present, these conditions are poorly ascertained by the healthcare system. And we know that early detection could significantly reduce morbidity and mortality. And once we identify people who have those alterations, there are clear steps that can be followed to improve the health and prevent disease. So to answer our question, does genetics fit within population health? The answer is yes. And to answer the follow-up question, where do we start? Well, it seems like a very reasonable position to start with the CDC Tier 1 genes because it fits these criteria that are described in the link in the previous slide that I provided. Besides the benefit to the overall population that we described by identifying disease ahead of time and treating it before we actually have to treat an advanced cancer or a cardiac event, we know that in an unselected population, we're going to be able to apply and provide meaningful health information to individuals who might not otherwise qualify to receive genetic testing. So a lot of genetic testing today requires you to sit with a genetics professional and for them to ask you questions about your family history. And if there's enough of a family history in that conversation, the genetics professional may decide to order follow-up diagnostic testing for a specific condition. That is similar, but not what we're talking about here. Here we're talking about all comers. Doesn't matter what your family history is. You just get this screening test done. If we don't find anything, we'll have a conversation about what that means. If we do find something, we can then take appropriate next steps. So this availability of testing for everyone is an opportunity for them to get tested when in the clinic they may get missed because they don't have a strong family history or they're adopted and they don't know their family history. And through this experience, we believe that these types of interactions will really help increase the genetic literacy of the general population. So when they go beyond just a screening curiosity and they have some type of real hardcore event that they want to discuss with their care provider, they've already interacted through this type of mechanism and they have a base understanding, base vocabulary and knowledge to share in dialogue with their healthcare provider. Okay, so let's share just a couple of examples that show how this is being done in the clinic. The Mayo Clinic is partnering, as I said earlier, with the Helix Laboratory to launch our own population genetics testing program. Within this program, which we call Tapestry, we call it Tapestry because we wish and desire and aim to weave the consumer and patient's genetic information with their rich medical history. And that woven fabric together creates their health tapestry to help us identify conditions they may be at risk for immediately, but then also, as time goes on, provide us with a resource that we can go back to over time to help understand their disease or help create tailored treatments for them. Within this Tapestry study, though, we intend to sequence over 100,000 patients over the course of 4 years. Described, we're doing this in collaboration with Helix, and so we'll be doing whole exome sequencing in practice, but by following the CDC's guidelines, we'll restrict that whole exome analysis initially to just the CDC Tier 1 genes so that we know exactly what we're dealing with and we know exactly how to train our clinicians in the next steps that will need to be taken in case they have any participants who turn up to be positive. Over time, we know that knowledge will expand, and we'll then look at those additional new genes to see if we can expand some of the valuable information that can be shared back with the participant. Our rationale for doing this is, number one, state of the art for patient care. We believe that we're on a trajectory from studies like this to commonplace. And so we really want to jump right in and begin using this to better the treatment of our Mayo Clinic patients. We also see this as not just a way to treat patients today, but a way to create a valuable data set that, again, in the Tapestry model, will weave rich electronic medical health record information with genomics information, and over time create cohorts that will allow us to solve more diseases. And that will create an enduring research legacy that will fuel Mayo Clinic research and discoveries for decades to come. But most importantly, I think we'll be able to improve health outcomes by preventing disease and not just treating disease. We're very early in the process, so I want to say that while we are enrolling Mayo patients, we're not yet returning results. And we do hope to get to that point early this year, although current situation with the COVID-19 pandemic will slow us down, but it will not drown our aspirations. Another population health study that we are working on is the Healthy Nevada Project. This is primarily a project between Renown Health System and Helix. Mayo Clinic is assisting them in some of the variant interpretations that they're finding in their population. But this study is quite unique in the way that it gathers individuals from the state of Nevada and northeastern California, over 500,000 people within that catchment that happen to be both multi-generational and also a diverse population within that area. And so that group, which houses a world-leading environmental research institute, has a similar goal as the Tapestry program, but they're trying to go after over 250,000 different individuals and use their information and their rich medical health information in order to study that population both now and over time. The enrollment of that study has been phenomenal. The group has enrolled over 10,000 people in the first 4 days. And in the first 6 months, they've been able to enroll, sequence, and return results to over 25,000 people. In the package that those people receive on the right of your screen, you can see that Helix will return back to them some regional health ancestry information. They'll learn some interesting traits. But more importantly, they're also going to learn about those CDC Tier 1 conditions. So that's hereditary breast and ovarian, Lynch syndrome or hereditary colorectal cancer, and familial hypercholesterolemia. When we look at that data over the first 6 months in those 25,000 people, we realized that 1 out of every 75 individuals have some type of alteration that impacts their life. So that's either a positive result in FH, in Lynch syndrome, or hereditary breast and ovarian cancer. The interesting thing that really drives home the value and the importance of population health studying is that over 90% of these people would not be detected in the regular medical practice. The group has gone back and taken a look at the medical records of all of the people who were identified with positive alterations and looked to see if they would have been able to predict disease just based on the reasons that they've been into the hospital thus far. Less than 20% of these participants had any documented suspicion of an inherited genetic condition in the EMR. And upon follow-up, only 40% had a family history relevant of disease. Only 26% of carriers had some type of manifested disease, with a median age of first presentation at 60 years old for hereditary breast and ovarian, 45 years old for Lynch syndrome, and 62 years old for FH. And on the very far right of the panel, I think what you can see in this Kaplan-Meier curve is in red, people who turned out not to be carriers and their health over age, versus those in blue who are carriers and their health over age. If you draw that line back to an area of where you can't really tell a difference between the population, you'll see that that's about the age of 30 years old. And what that suggests is if we would have tested these people, not in their 60s or beyond, but if we would have tested them before 30 years old, we would have been able to put into place other types of care that were either prophylactic or heightened monitoring that may have helped catch their disease before they had some type of negative outcome. Again, suggesting that prevention is better than treatment. Not that you don't have to do both, but prevention is more valuable than treatment alone. Okay, so I think through that, we understand what population genetics testing is. We've shared some examples of a couple projects that are being run by Mayo Clinic and Renown Health. Now I want to discuss with you some of the trickier parts that go into building a program like this. So I think one of the main challenges is understanding in a population health screening approach, how do we do variant interpretation? We also have to take some considerations, some time to consider what it means to set up an effective program and what needs to be put in place in order to establish an effective program. And then, of course, none of this is without risks. So let's take a peek at some of the risks. But first, I'd like to say a couple words about variant interpretation. There's been a couple nice papers published that look at the space of genetic testing without a clinical condition or a clinical indication for testing. We've called this elective genomic testing. And we've talked a little bit about not just how to do variant interpretation, but how do you design the right assay for a population health study. In my day job, I typically work within the clinical diagnostic lab, and within that laboratory, we have people who come in with really strong family histories of disease, and in that cohort, we want to use what I call a leave no stone unturned approach, where we really use multiple methods in order to identify alterations, and we comb through every last piece of literature to understand all variants that we find within that individual to know whether or not they have disease or not. That's not rapid, and it's not cost effective. So what can we do in a population health screening modality that allows us to look at the most likely suspects in a rapid and cost-effective manner? One of the key pieces to that is to eliminate the need to interpret variants of undetermined significance, or VUSs. These are the most difficult variants to evaluate, and they're also very difficult for clinicians to know how to change or manage their patient health care following the receipt of a VUS report. So when you're talking about an otherwise healthy population, we don't want to make it difficult for clinicians to use. We don't want to cause a lot of undue follow-up assays and testing. So we believe that you need a higher level of certitude when reporting in population health testing or in elective genomic testing. Good news, there are guidelines for how to do this. It's not a direct corollary or overlap, but the ACMG created recommendations back in July of 2013 that described what to do when you're doing large genomic sequencing studies and you find an incidental finding. This is a finding that is not the reason why you were originally performing the sequencing. So let's just say, for example, we are doing whole exome sequencing on an affected child, a healthy mother, and a healthy father. And through that sequencing to try and identify why the child is sick, we find out that the mother is a carrier of a BRCA1 or 2 mutation, hereditary breast and ovarian cancer. Well, the ACMG policy statement said that if they opt to find out about secondary alterations or secondary findings, you should report that out. But when you're reporting that out, only report out pathogenic and likely pathogenic variants, or for some of the conditions on the list, really only sticking to known pathogenic variants, so that while they weren't expecting this result, the clinician and the patient know that for certain there's action that can be taken to help treat, advise, take the next steps for this individual. If we were to report back a variant of undetermined significance, it creates a lot of alarm, a lot of caution, and can be a very difficult situation for both the care provider and the patient to navigate. So the help from the ACMG in these types of tests say, stay away from VUSs, focus on what's known to be pathogenic or likely pathogenic, and that's the line of certitude that you need to have in a population health type study. Some considerations. Who should have this test done? Well, I believe that everybody should, and I do believe that at some point soon, everybody will. It's most impactful right now when limiting it to things like the CDC Tier 1 to adults under 30 or 40 years old before they've manifest some of these diseases. So if we find them, we can go through heightened surveillance, or we can do other prophylactic measures in order to make sure that they don't succumb to the more advanced and aggressive stages of these types of diseases. If we were to have a conversation around pharmacogenomics, or PGX as it's abbreviated in this slide, we could see that the numbers here are vastly increased. So pharmacogenomics relevant findings are in about 99% of all of us. And as you know, as we age, we take more medications. So the age at which these types of studies would be beneficial is anywhere from under the age of 40 all the way to over the age of 80 years old and plus. As the number of medications go up, you want to know how your body metabolizes those medications in order to avoid any type of adverse reaction. The big question that we get is who will pay for it? This all sounds really interesting, but what's it going to cost? A lot of direct-to-consumer testing in the beginning has been self-pay. Personal individuals have paid for this. But my belief is that that type of consumer testing is on the decline, and people are actually going to notice that it's the health systems and the insurance providers themselves that are most interested in better managing their populations. And when they do that, there are cost savings to the overall program. so significant that they will be willing to pay for it themselves. And I don't think anyone's going to make this type of testing mandatory, but it's certainly going to get to the point where if you want it, I believe your provider will pay for it. The reason for that, I think, is pretty simple, and it really comes down to how society overall benefits from these types of proactive healthcare decisions. You can see, and we all know that prevention is worth over a pound of cure. And this very eloquent, although mathematically very challenging to get through, article here from the Journal of Health Economics really applies mathematics to really describe the value of disease prevention versus treatment. And at the end of the day, it's no surprise. They clearly show that while treatment and cures are very important to prolong life for people later in life and later in the stages of their conditions, preventing those conditions from the outset are far more effective, both from long-term health benefit and from a cost perspective than actually acting in a more reactive fashion. So clearly these types of tests, proactive tests, are going to benefit society broadly by both increasing quality of life, life expectancy, but also reducing the cost of care. It's not all ponies and rainbows. I'll freely admit that, although, as you can tell, I'm a pretty ardent supporter of population health. Some of the fears that I worry about are the false sense of health security. I don't need any colonoscopies because I took this preventative health test and I don't have, quote unquote, the gene for breast cancer, or in this example, for colorectal cancer. And that's just not true. Remember, we went back, we talked real briefly about the completeness of the test. In the diagnostic laboratory, we leave no stone unturned. In the screening application, we're doing the best that we can to find the lion's share of variance, but certainly we're not leaving no stone unturned. Also, from an interpretation perspective, we talked about how we're not returning any VUSs. Most VUSs will remain enigmas for a long time, but some of them are actually very important and will be elevated to pathogenic alterations or likely pathogenic alterations over time. So those two reasons alone allow you to see that there is a bit of incompleteness in these types of tests, not in a negative way. Again, we couldn't do population health if we tried to leave no stone unturned and report all VUSs pathogenic and likely pathogenic variants. But there is a small chance that somebody who tests negative by these types of screening tests still have an alteration that could not be identified. So we need to be sure to let people know that even though they didn't have a positive test result, they should abide by standard population testing guidelines for the standard screening protocols like self-breast examinations or colonoscopies after a certain age, or talk with your physician about your cardiac health and whether or not you need to be put on a statin. Don't just rely on the genetic testing. Another thing that we should be concerned about is genomic discrimination. I think that's very real. It's a very real concern, I should say, that people have. But luckily, we have laws in place in the United States that help to protect people against any type of genetic discrimination from your employer. And that would be the Genetic Information Non-Disclosure Act, or GINA. The other concern that we hear about frequently is data security. How do I know that your system isn't going to get hacked and all of my genetic information is going to be out into the open? Well, for the Mayo Clinic at least, all of these types of studies treat any of the information as if it were any other medical record data point. And this is something that Mayo Clinic has been doing for over 100 years. And we feel very strongly that your genetic information is no different. So it gets treated with the same type of of attention and security that any other medical health information would be managed here at the Mayo Clinic. And then from a privacy perspective, again, from a Mayo Clinic perspective, this will vary by program from institution to institution, but a lot of academic programs are not interested in selling your data to third-party providers or pharmaceutical companies for research. It really is their mission to advance their own internal research to help make discoveries and help cure diseases. So in closing, I'd just like to wrap up with saying that there's a very strong potential here to shift the healthcare equation from prevention to prevention. Over treatment, ounce of prevention is worth a pound of cure. I believe that this is going to become the standard of practice. We're engaging, and many across the country and globe are engaging in these types of studies to prove that fact. But it will eventually become the standard of practice. I think another challenge that I didn't describe in the previous slide is that education continues to be a top concern and priority. We need to be thinking about not just how we educate the consumers so we can raise their genomic literacy, but also how do we educate the caregivers so that they feel comfortable with this information when they're sitting down with their patients and their consumers. This can all be a little bit stressful because we don't like change. We like to figure out our lives and then get very efficient and rapid in managing a routine. But the fact of the matter is the only constant things in life are change. So let's embrace that journey. With that, I'd like to thank you for your attention and really just welcome you to ask any questions that you might have about this talk or other population health or diagnostic genetic testing questions you might have. My email is listed at the bottom. Please stay safe, and we're all going to get through this. Better times are in front of us. Thank you very much, and enjoy the rest of the virtual sessions.